The following podcast is part of a certified educational activity titled Beyond Snoring, diving into the spectrum of obstructive sleep apnea screening tools. Access the entire activity and complete the post test at peerview.com/UXN860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Rafael Sepulveda from Sleepfit Medical in Sonoma, California. Our goals for today is to increase your skills in identifying the ways that OSA may present in primary care, equip you with strategies to use screening tools to evaluate patients with suspected obstructive sleep apnea. Why focus on obstructive sleep apnea? So, OSA is a potential lethal disease that can increase the risk for numerous health problems, including cardiovascular disease. Patients with obstructive sleep apnea who are diagnosed and treated can experience improvement in their sleep quality, heart health, obesity, and overall well being. It is imperative that primary care providers and other health professionals to identify patients with symptoms of obstructive sleep apnea. Common symptoms might include snoring, gasping, choking, and silent pauses in breathing during sleep, as well as excessive daytime sleepiness and fatigue. So, what is obesity-related sleep disorders? So, there's a variety of sleep disorder breathing disorders: obstructive sleep apnea, central sleep apnea, and upper airway resistance syndrome. Obstructive sleep apnea is the most prevalent and is sometimes related with obesity. Central sleep apnea may co-occur with obstructive sleep apnea and may be induced by CPAP, which is what we call iatrogenic. Upper airway resistance syndrome is a milder level of sleep breathing disorder where the respiratory disturbances cause arousals or short awakenings during sleep. Obesity hypoventilation syndrome is typically has prolonged daytime hypercapnia, and 90% of them have comorbid obstructive sleep apnea. Insomnia, primary snoring, and restless leg syndrome are other obesity related disorders. So, what is obstructive sleep apnea basics? What is OSA? So, is basically episodes of complete or partial collapse of the upper airway during sleep, resulting in intermittent hypoxemia, arousal from sleep, and fragmented non-restorative sleep. So, what is the definition of apneas? So, apneas are a decrease in airflow of more or equal to 90% for more than 10 seconds. Then the definition of hypopnea is a decrease in airflow of more or equal to 30% for more than 10 seconds associated with a decrease in oxygen saturation of 3% or more. Um, and according to CMS criteria, a decrease in airflow of more than 30% for more than 10 seconds is associated with more than 4% associated desaturation. Um, now, how do we assess severity of obstructive sleep apnea? So we use this index called apnea hypopnea index, which basically means how many times the patient had an obstruction of their airway. In a normal patient, if that number is less than 5, is considered physiological. If it's 5 to less than 15, it's considered mild. Moderate is considered 15 to less than 30, and more than 30 is considered severe. Now, what is the association between obstructive sleep apnea and insomnia? So, insomnia is basically the difficulty falling and staying asleep despite adequate opportunity, leading to daytime impairment. And it affects around up to 35% of adults, especially older adults, women, uh, patients under stress, or with mood disorders. And the diagnosis is purely clinical, and it does not require a sleep study unless sleep apnea is suspected. Now, what is the association between mood disorders and obstructive sleep apnea? So, this study showed that in between 1,390 adults with obstructive sleep apnea, 15.5% had symptoms of depression and 14.4% had symptoms of anxiety. And that was compared to a control group with primary snoring of 125 participants who had the same comparable rate of depression. Um, Depression and anxiety were more closely linked to mild obstructive sleep apnea in comparison to severe obstructive sleep apnea. And patients with depression and anxiety are more likely to have nocturnal awakenings than actual symptoms of sleep breathing disturbances. What are the sex difference in obstructive sleep apnea? So, obstructive sleep apnea is more commonly diagnosed in men, but women often experience more severe comorbidities at the time of diagnosis. Sex difference in OSA may stem from normal sleep pattern differences, variations in symptom presentation, and differences in risk factor prevalence. We believe that hormonal and physiological changes across puberty, menstruation, pregnancy, and menopause can increase women's risk for sleep disorders. Um, Sex difference in obstructive sleep apnea may be partly due to underdiagnosis in women, especially at the early stage of obstructive sleep apnea. Women with obstructive sleep apnea are often present with symptoms like depression or insomnia, leading to a misdiagnosis. OSA is estimated to be underdiagnosed in up to 90% of women. Now, in terms of clinical presentation, men usually present with classical symptoms, excessive daytime sleepiness, higher blood pressure, snoring, and witness apnea, especially with alcohol and tobacco use. Um, and there's a higher prevalence of what we call non-supine and non-sleep stage related obstructive sleep apnea or generalized OSA. In women, there's a lot more frequency of non-classical symptoms. So they report less snoring, less apneas, and they report more fatigue, insomnia, headaches, and palpitations at night. Um, and sometimes it coexists with depression or hypothyroidism. There's a higher prevalence of um, staging REM-related obstructive sleep apnea and mild severity obstructive sleep apnea, which is what we call non-generalized. At the time of obstructive sleep apnea diagnosis, women with OSA are more likely to be treated for depression than men with the same severity of obstructive sleep apnea. Now, screening and referral for symptoms occurring during menopause should be including sleep disturbances. And some resources that we can use is the Promise 8 questionnaire as well as the Stop Bang. Promise 8 is for insomnia and Stop Bang for obstructive sleep apnea. And if there's a screening of sleep disturbance that is positive, considering a sleep specialist follow up and sleep study is recommended. Now, the ASM Health Advisory Committee recommends screening in patients with different heart conditions because sleep apnea hurts the heart. And those patients that should be screened annually are patients with heart failure, elevated blood pressure, atrial fibrillation, resistant high blood pressure, diabetes type 2, and stroke. Additionally, some patients that should be screened are patients that have a BMI higher than 30, nocturnal dysrhythmias, pulmonary hypertension, or coronary artery disease. And any patient considering bariatric surgery should also be screened. Now, what are the screening questionnaires that we can use for sleep disorders and obstructive sleep apnea? The StubBang is the main initial screening tool that is validated for OSA. This was developed for presurgical risk assessment in patients with moderate to severe obstructive sleep apnea. The Berlin Sleep Questionnaire is mostly focused in obstructive sleep apnea symptoms in patients at high risk of obstructive sleep apnea. F4 sleepiness scale, it measures daytime sleepiness rather than obstructive sleep apnea, but it's a easily self-administered questionnaire that can be done in clinic. And the Pittsburgh Sleep Quality Scale assess overall sleep quality in adults within a 1 month frame. The Insomnia Severity Index is a questionnaire for patients complaining of symptoms of insomnia, and it's a self reported questionnaire that can give us an idea of the severity and impact of insomnia in their daytime living. Now, how should we screen these patients? If there's a high suspicion of obstructive sleep apnea, a diagnostic study, either at home or an attended sleep study, should be pursued. If there's history of obstructive sleep apnea diagnosis or current symptoms, but not current treatment, we should consider either a sleep study, or if reach out for previous sleep study results if they're available. If they're not available, then should be referred to a sleep specialist that is board certified, or retest prior to sending for referral. If there's a patient with an diagnosis of obstructive sleep apnea as is not actively being treated, or with poor tolerance, it should be referred to a sleep specialist. And if the patient refuses or is unsuccessful with primary intervention, then consider other alternatives like dental appliances, ENT referrals, or even behavioral health if there's needed for insomnia management. Now, what are the different types of sleep studies? So, an attended sleep study called a polysomnography, or what we call a type 1 sleep study, is the gold standard for obstructive sleep apnea diagnosis. It collects more detailed data and it provides the most accurate diagnosis. It's done in a sleep lab or a hospital based lab. Um, Usually, if there's a home sleep apnea test that is negative or what we call inconclusive, this should be the type of test that should follow. Also, in patients with high risk, like cardiovascular disease, comorbid respiratory conditions, neuromuscular conditions, or prior stroke, should be first screened with an attended polysomnography. Now, home sleep apnea test is what we call a type 2 and type 3 study, which use less sensors than a regular attended study. These are mostly used for uncomplicated adult patients presenting with signs and symptoms that indicate a high risk for obstructive sleep apnea. And all home sleep apnea testing should be accompanied by a comprehensive sleep evaluation. Now, peripheral artery tonometry is what we call a type 3 study, and this basically measures changes in the sympathetic tone by monitoring blood volume in the distal most tip of the finger. Accuracy is higher in patients with moderate to severe obstructive sleep apnea. Overnight oximetry and overnight digital monitoring is the newer high resolution wireless oximeter with a smartphone application using a cloud algorithm to detect desaturations accurately. However, this is mostly done for primary screening, which can help clinicians detect patients that are at high risk of obstructive sleep apnea. Now, primary care physician diagnosis and management of sleep disorders. Is it a viable option? So there's this meta-analysis from Spain and Australia that show that primary care providers managing uncomplicated obstructive sleep apnea, and the comparison between a sleep medicine specialist care. Um, in terms of findings, there was a non really clinical significance in terms of their care. And there was a slight reduction on daytime sleepiness in the primary care provider group. So, this demonstrated feasibility of sleep testing in primary care, as well as primary care being able to effectively manage uncomplicated cases of obstructive sleep apnea. However, it remarks that complex patients with comorbid conditions should be referred to a sleep medicine specialist. In Australia, currently, primary care providers are able to order home sleep testing based on clinical findings and screening questionnaires. So, key takeaways from this activity: sleep disturbances often stem from multiple factors, with obstructive sleep apnea being among the most common causes. Primary care clinicians are well positioned to screen for obstructive sleep apnea, as well as other common and often co occurring causes of sleep disturbances. Primary care clinicians can perform some diagnostic tests for obstructive sleep apnea, but referral to a sleep specialist may be needed for definitive diagnosis. And embracing the conversation on sleep quality in primary care setting can improve health outcomes in patients. That concludes our discussion for today. I hope you found the activity informative and that you will feel more confident about using screen testing for obstructive sleep apnea in your primary care practice. Be sure to download the slides, and thank you so much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/UXN860.